This is presented by Dr. Julio Garcia Aguilar from Memorial Sloan Kettering, who's done a fantastic job of organ preservation and rolling back the use of TME, total mesorectal excision, for patients who have low-lying rectal cancers and who have responded to neoadjuvant chemotherapy and chemoradiation. In the Memorial experience has been published, and in their hands, it looks like people who have pathologic complete response rates can be watched and with very close surveillance by the surgeons. They do their own flexible sigmoidoscopies and watch these patients very carefully every 4 months. It seems like a third will relapse, but almost all of those can have salvage surgery at that point. So this study was a little different than that because it didn't specifically ask that question, but it was more to look at neoadjuvant chemotherapy and then continue on, and radiation, and then continue on to appropriate rectal management, which would include watch and wait for people who had clinical complete responses, but go for the TME if they needed it, if they didn't have it. So this was randomized between two arms. One started with chemotherapy and then had chemoradiation afterwards, and the other one had chemoradiation first and then the chemotherapy second, and the surgery if needed third. So this is more like a not comparative study. It wasn't that big. It was originally 200 patients, and then they expanded it to 300 patients, but it was supposed to kind of validate the approach. And instead of having a 75% survival, disease recurrence-free survival at 2 years, they were looking for 85%. And it was about 80% in this. It wasn't quite 85, so didn't quite make the primary endpoint, but the watch and wait group did very well, as the TME group, and it did seem to validate the approach of watch and wait for people who had a clinical complete response. Most interestingly, to come out of this, and I think unexpectedly, was the group that got chemoradiation first, followed by the chemotherapy second, seemed to have a lower rate of local recurrence. And I'm not sure quite how to explain that, but maybe I've always thought that you give the chemo first and then it reduces the size of the tumor and the radiation will work better at that point. But it seems like the opposite order actually reduces the local recurrence rate. So that could be one very interesting aspect of treatment that comes out of it. I think there are a lot of issues today with locally advanced rectal cancer. Can we get away from doing the 5 to 6 week of long radiation, do the 5-day short course? You know, if you do the 5-day short course, there's data from Europe. If you do the chemotherapy, then you have a really high response rate by the time you get to surgery. One of the reasons being that if you operate too soon, you don't have as high of a pathologic complete response rate. It takes a couple months to really get to that pathologic CR if you do the short course radiation. If you operate a month early, it may not make a difference in the long run, but if you're looking for pathologic CR, you're going to see fewer than if you wait 2 or 3 months. So I think the field is really evolving in terms of how to use the radiation, how to sequence the chemotherapy, move the chemo first instead of after the surgery, and then finally not operating on people. Maybe a third of patients can undergo organ preservation. This is a rapidly evolving, or certainly evolving, area of practice today, and the questions that are being raised and the data that are presenting are really very interesting. It's hard to know if any of these trials in and of themselves will be practice changing because it's very complicated to do appropriate comparative phase 3 trials, such as preoperative versus postoperative chemotherapy for rectal cancer, is a trial that probably won't ever be done. So, because it's not practical and people kind of feel like they know the answer already. So I think that it will change practice and that we're going to be moving the chemotherapy and the radiation first. I think the questions of long course versus short course radiation need to be studied in greater detail, but the practice is changing. It's just slower to change. There's no one definitive study.